and then we'll get started. For those who don't know me, my name is Heather Redmond. I use she, her pronouns, and I am the Strategic Initiatives Partnerships Coordinator in the Public Health Division at the Oregon Health Authority. If you've been to these before, you should recognize me as your host and facilitator. And I'm not going to take up too much time introducing myself, as we have two awesome presenters here to talk to us about the oral health program at OHA. So as they're getting ready, setting up to give their presentation, I would like to invite you all to share, introduce yourself and share who you are in the chat. So if you could please put your name, pronouns if you want to share those, where are you coming from? What organization or part of the state are you representing in this meeting as a learner and a community member? And then if you could think about, as we're in the middle of fall now, and a lot of folks around the state are seeing the changing of the season through the weather and also through nature. What is something that comes up for you in fall that reminds you that you are also capable of change? So if that is, and you don't have to answer the question, but just think about introducing yourself, name, pronouns if you wish, where are you coming from, and what's something about this season that reminds you that you are also capable of change. So I'm going to go ahead and mute myself, pass it over to our presenters, and wait for folks to share some fun things in the chat. Amy, I see you're on camera. So I'll pass it to you.
Morning, everyone. Can you guys hear me and actually see my slides? And I apologize. Are we?
I can hear you and see slides, and I see a couple of thumbs ups happening.
Okay, and you're not seeing any notes or anything like that, right?
We see the presenter view. So just to do a little swap.
Okay, I'm just trying to figure out how to do that.
If you go up to display settings at the
Yeah,
top.
thank you.
Yep.
Okay, is that better?
Yes.
Okay, thank you. Well, good morning, everyone. My name is Amy Umflett. I am the team lead for the oral health program in the public health division. And I am joined this morning. Sarah, do you want to introduce yourself really quickly?
Sure. Hi, everyone. My name is Sarah Kowalski, and I'm also a policy analyst with Amy in the oral health program. And I'm also a hygienist.
And we're going to be providing kind of an oral health overview of the work that's across OHA, as well as more specifically that we do here in public health. And we are going to focus a lot of our time on a hot topic, at least in our world, which is fluoride. Again, I am at the Portland State Office Building, and I have two screens. So I'm sure that my view, if my head is moving, is just because I'm maneuvering two screens. And just please feel free to jump in if you have any questions as we go through the material. We kind of have natural breaks in between each of the primary topics, but we'll go ahead and get started. What's unique about us in public health is we actually work very closely with our counterparts across the Oregon Health Authority. So we have an OHA oral health team, which meets every other month. It's a large group that includes any staff that works on oral health, dental health, like a portion of their position may be impacted by oral health, and they'll attend those meetings. And mainly we stay updated on what's happening across the agency. We do participate in core team meetings. We have program leads, which myself, since I'm the team lead, I represent public health. We meet with our dental director, which sits in the Medicaid program on a regular basis, and we kind of deal with strategic planning, any high priority issues, as well as facilitation for the larger OHA oral health team. But specifically in public health, where the majority of oral health staff for the Oregon Health Authority sits, here are like our focus. And obviously our goal is to improve the oral health of all Oregonians across the lifespan. Although a lot of the work that we're funded for or that we have capacity for is focused in child in child oral health, and that's why we sit with the family and child health program here in public health. We do school programs, so we certify all school dental sealant programs before dental sealants are provided in the school setting, which most sealant programs operate in elementary and middle schools. Some do go into elementary schools too across the state. We have an Oregon oral health surveillance system where it has over 64 data indicators that we compile that impact oral health. We have workforce initiatives. For example, we used to have the Dental Pilot Project program where innovative workforce models were tested before like licensure. For example, dental therapist, which is a mid-level provider similar to nurse practitioner, was tested as part of the Dental Pilot Project program. And then legislation happened that now Oregon allows dental therapy. We provide technical assistance to local public health agencies and tribes that are interested in working on improving and increasing oral health preventive services for pregnant women and children is part of the Title V Maternal and Child Health Block Grant. We have some work around preventing oral HPV and increasing vaccination among the dental community. Oregon's one of the few states that allow dentists to administer all types of vaccines, not just flu or COVID like a lot of other states, but all types. And we know that oropharyngeal cancer, which is cancer of the mouth and throat, we've seen a significant increase, especially in males, around HPV-associated oral cancer. And then a lot of our work is doing around health education on trying to maintain and increase good oral hygiene because we know that improves, health outcomes, and the mouth is part of the body, is what we usually say. So those are just kind of our primary work as part of our work in public health. Some of the data that we capture, like the for the surveillance system, we're highlighting here. So for our certification program, we have 19 certified school dental sealant programs. They served around 790 schools during the 24-25 school year. Over 63,000 students screened for sealants, and then over 91,000 sealants were placed across the state. So for the current 25-26 school year, we have 17 local school dental sealant programs are certified. And then one, we have provisional certification that we're working with to get fully certified. And we mainly certify them to make sure that dental sealants are applied safely in a school environment. Dental hygienists go into the schools using mobile equipment to apply those. Again, we are a surveillance system. We compile the data indicators from a lot of surveys, for example, behavioral risk factor surveillance system, PRAMS for pregnancy and children, I think ECHO, which is for children that are 2 years old, the student health survey, we have oral health questions. But one of the primary data sources that we've been doing is we ourselves actually facilitate the Oregon Smile and Healthy Growth Screening, which is done every 5 years. So we contract with dental hygienists to go into elementary schools, and they go ahead and screen first, second, and third graders to get the oral health status as well as the overweight and obesity status of children in Oregon. It is prevalence data, so it's a single point in time. And one of the limitations of doing it is you can't assign one intervention has either made improvements in the oral health status or, has made it worse. So for example, while a lot of it would, our efforts to do school dental sealant programs, while we would love to say that it contributes to improvements in the oral health of children, we can't say that that or like community water fluoridation is the reason why the rates are so low. So, and you guys are the first group to get preliminary data from our last SMILE screening effort. It took us 2 school years to get data collection for the sample size. So it is preliminary. We're still working with the Oregon Department of Education on getting demographic data. So it's not complete and we don't have the report yet. But we can say for the 2022 SMILE screening, 53% of kids in 6 to 9 year olds, first to third grade, had a cavity. That's still basically 1 in 2. Out of those that had cavities, 32% had treated cavities, and then 22% primarily had untreated cavities. And in our world, most cavities are preventable. So it's still really unfortunate that 1 in 2 kids at elementary school age have had cavities. So over time, you can see, like I said, we do this every 5 years. We've seen a small uptick in the rates since our last smile screening in 2017. But we can say, COVID-19 happened since the last time. So while there is a slight, increase, for example, any decay, currently it's 53%. In 2017, it was 49%. Um, the data, it could have been a lot worse given COVID-19, the school shut down. So we, there's a lot of work to still do. Like I said, we still have, over 50% of kids have had cavities. So there's still a lot of work to do, but it could have been a lot worse given COVID-19 happening. We obviously have some geographic disparities in rural and frontier Oregon. The decay rates are significantly worse, as you can tell in Regional 5. It is statistically different from the statewide average of 53. So, oral health and how it relates to public health modernization, we primarily see ourselves in 2 buckets, and the first being prevention and health promotion, because that's a lot of our work. But then we also see ourselves in access to clinical preventive services, since we do certify school dental sealant programs and promote oral health services in schools, school-based health centers. We partner a lot with school-based health centers around that as well. When modernization first came out and the first set of accountability metrics, um, the group recognized the importance of oral health, and they actually included a developmental measure, dental visits for 0 to 5-year-olds. And the reason why it was developmental is the leverage that we have. So local public health authorities and tribes don't have to work on oral health. There's not a steady funding stream to work on oral health. So it's pretty much, optional. We love to work with them on at least referring for oral health if needed. A lot of WIC programs partner and have dental hygienists come in and do baby days where they're doing screenings and fluoride varnish for really young children. But recognizing the importance of oral health, but there's really not a lot of leverage in the public health system for moving some of the oral health work, because we just don't have funding sources and statutory requirements outside of school dental sealant program certification. So for the state health assessment, we have 2 data indicators, water fluoridation and dental visits among children. For the next state health improvement plan, which I think the report hopefully will come out early next year, our oral health strategies promote routine dental care by increasing public and provider education, preventive treatment, and collaboration with providers. So the system of care for oral health, a lot of our leverage is really kind of through the Medicaid system versus the public health system. But I do want to highlight to you that through healthcare.gov, the tax credits that people may get for medical plans, they can't be applied to a standalone dental plan. Now, while some of the medical plans may include dental, a lot of dental is a standalone and they would have to pay extra for that. Oregon's lucky in that we are a Medicaid expansion state with health system transformation and the creation of the coordinated care organization model, and that we have comprehensive adult dental coverage. Because before health system transformation, adult dental coverage was limited to only emergency dental. And then we always want to remind people that Medicare plans do not cover dental coverage. So low-income seniors can be dual eligible and they can get comprehensive dental coverage through Medicaid. But Medicare recipients have to pay separate for dental services. So there is a large disparity gap with that. So CMS, as kind of mentioned before, they require Medicaid to provide dental benefits to children, but they do not require dental benefits for adults. So state legislative approval to use state funds for adult dental. Um, Now, while the CCO model launched in 2012 and they were responsible for integrating oral health, dental care was actually the last to be integrated into the model in 2014. And the way that it's kind of been working is that CCOs contract with dental care organizations, which were those entities that were providing Medicaid services before health system transformation. So this is like Advantage Dental, Capital Dental, and then CCOs are also contracting with independent dental providers and offices to fill those gaps. And beyond just the CCO structure, these are some of the DCO subcontractors that you may have heard of. Advantage, Capital, Care Oregon, Kaiser, ODS, and Willamette Dental Group are the main ones. So some dental benefits that are unique on the Oregon Health Plan is there are additional dental benefits during pregnancy and then 12 months postpartum. They get additional teeth cleanings, prefabricated crowns, and then root canals and back teeth. In 2023, the legislature passed bills that created two dental-only programs, one specific for Oregon veterans, because veteran benefits do not cover dental services. So, and then the next one is for COFA, for citizens do not qualify, and then for those who don't qualify for OHP, which would have gotten comprehensive dental services. And then when the EPSDT changes expanded, it now includes handicap and malocclusions, which covers orthodontia under certain circumstances as part of that benefit as well for children. Now, the CCO performance metrics for this current year, there's technically 3 oral health incentive metrics. The preventive dental or oral health services one is also a challenge pull metric. So the CCOs pay extra attention and make sure that they meet that. In 2026, unfortunately, one of the oral evaluation for adults with diabetes dropped off as an incentive metric. So there's really only going to be 2. And then I'm sure you guys have heard that physical and dental health assessments is changing from 60 days to 30 days, while mental health assessments is not changing. It's continuing to stay at 60 days for children and child welfare. So we also partner a lot with the safety net clinics. So federally qualified health centers, rural health clinics, and tribal clinics, they don't have to provide oral health services beyond being able to refer for oral health. But a lot of FQHCs do include oral health services on sites, some rural health clinics, and then some tribal clinics also provide oral health services as well as part of the Indian Health Services. So some of the challenges that's out there, and it's probably not unique to oral health, or you probably are already aware a lot of these, but we do want to call it out. Again, we have a huge lack of access problem around among low income, rural, and underserved population groups. We have a lot of dentists in kind of the I-5 corridor of Oregon, but in rural and frontier areas, we have fewer dentists compared to the residents that they can serve. The data is a little old in 2019, but we also have a lot of dentists that just do not see Medicaid clients. So 2 out of every 5 dentists report seeing Medicaid patients. And then a lot of dentists, they may accept Medicaid clients, but they're only restricting it like only 5% of their client caseload may be Medicaid. So they do kind of restrict the number of it, which impacts access to care significantly. So 33 out of 36 counties in Oregon is technically designated as a dental HPSA area, so health professional shortage area. For provider issues, again, we have workforce shortages around dental hygienists, especially dental assistants. There is a issue around diversity in the workforce, and I'll provide some data around that. Um, there is some recruitment and retention. There's high absenteeism that really impacts provider service levels. When I talk about the diversity, this is kind of a stark realization that especially around gender and age. For example, blue is highlighted dentist, and then the bar in orange is dental hygienist. So the majority of dentists in Oregon are male, while the majority of dental hygienists are female. Dentists are a little bit older, the dental hygienists. And then let's see, get to the, whoops, why is it not moving? Hang on. Okay, sorry. And then around race and ethnicity, the majority of both dentists and dental hygienists are white, but you do still see a little bit more diversity and demographics around dental hygiene than dentists, for sure. We have heard, and the largest challenge that we hear constantly is that it's taken me a long time to get to see a dentist. And sometimes the wait for initial appointment can be up to 9 months. There's just a backlog of people that need to be seen. There's language and culture barriers on top of the diversity. It's dentists are not, dental offices can be small mom and pop ones, and they just don't have a large infrastructure. So they're not quite sure how to work with interpreters. And again, when the diversity of the workforce is lacking, there's just not a lot of non-English speaking workforce that can work with clients. And then with access issues, there are difficulties finding providers that can serve really young children and people with intellectual and developmental disabilities. And then another challenge, which we're just not quite sure of, is the future of uncertainty with a lot of areas in public health is obviously comprehensive dental benefits for both children and adults, but mainly adults, could be at risk as we go through some budget conversations in the future. And I'm going to go ahead and pass it over to Sarah that's going to talk to you about our hot topic. So let me stop sharing so she can stare her screen. But before I pass it over to Sarah, is there any questions so far as to kind of the system of care and oral health in general that we have in public health? At Karima, I see a hand. Sorry.
Hi, thanks. You just mentioned the accessibility issues, and we, as Oregon Spinal Cord Injury, have one huge accessibility issue that we're trying to compensate for is the fact that wheelchair users can very often not have access to dentists because they cannot transfer out of their chair. There is no equipment to help them transfer out of the chair. The staff is not trained. And that's a huge issue in our community. And we're actually just received funding from one of the CCOs to acquire a specific chair that allows wheelchair users to roll into that chair, and then that chair can be used by the dentist to recline and enable access to the wheelchair user without them having to transfer out of their chair.
Absolutely. I mean, we've heard that that's a significant challenge. I mean, there are some, and like I said, there's the need is so much more out there, but there are some dental hygienists and, the intention around dental therapies, once we get enough licensed dental therapists, is that they can go out into the community and reach those people either in nursing homes, at home, and actually provide care like in their chair so that they don't have to go to the clinic and they don't have to transfer to dental clinics. But again, like I said, it's just not widely, there's just not a lot of wide network of programs, unfortunately. Like I said, we have a lot of access to care issues. And I mean, I don't want to lie to you guys. I don't see a lot of improvement over the short term, and it's going to take us a long term to get enough workforce, get enough of them to accept Medicaid, and then to be able to have the workforce that can go out to the community beyond just the dental clinic. And I don't know, Sarah, if you want to, jump in there. I just don't want to, we know that there's a lot of challenges, and unfortunately, I don't have a lot of good news on that's on the horizon.
I was just wondering if you could add to your presentation, because you had intellectual and developmental disabilities, if you could add physical disabilities as well.
Absolutely.
Thank
Yeah,
you.
we would love to do that.
It's a matter of representation and showing that this is also a population that is impacted.
Absolutely.
Thank you.
I'm going to go ahead and attempt to share my screen. So please let me know. Same thing. I'm not used to Zoom. So I'm going to do this and cross my fingers that I can do the slideshow. And I think here you're seeing everything.
So you can see the slides, we can see all of them. So as long as you go to the bottom and hit start slideshow, then it should pop up for us to be able to see it from slide to slide instead of seeing the slide deck on the side.
Start slideshow on PowerPoint?
Yes. Yeah. And right now I just see the background of your computer screen. The slideshow is now not showing.
See that now?
There we go. Yeah.
Okay. All right. So you see my great big thing that says, what is fluoride?
Yes. With
And my
the
toothpaste?
tooth. Mm-hmm.
Wonderful. Okay. So I'm going to move you all over here so I'm not looking at myself. I'm going to talk about fluoride, and this is a hot topic for lots of different reasons. First, I want to talk about, and I'm going to take you a little bit back and talk about what exactly is fluoride. So let's back up and first, fluoride is a chemical ion of fluorine, which is an element seen here on the periodic table of elements. And fluoride ion is considered a trace mineral. So fluorine is an element, like I said, it's extremely electronegative. And it's extremely reactive. So it likes to grab onto electrons, and it wants to do so to become stable. So think back to college chemistry if you had the privilege. In the process, you pick up an electron and it becomes a negative ion, and it becomes fluoride. Fluoride can be found in various chemical compounds. Typically, it combines with other elements to form stable substances. Examples that you most commonly probably see on the side of your toothpaste is sodium fluoride. That's used dental products and in water fluoridation. Sometimes you'll see it as calcium fluoride, which is found naturally in minerals. And then hydrogen fluoride is a highly reactive and corrosive compound that's used in manufacturing and etching. And a lot of misinformation around fluoride, and I think some lack of understanding of chemistry. But think of fluoride as a flavoring ingredient like sugar. So just because two things contain sugar does not mean they are the same thing. So even though both of these hydrogen fluoride contains fluoride, same as sodium fluoride, does not mean they act the same. So I just want to stress that point. Fluoride is found in soil, water, and many foods. It's the 13th most abundant element on Earth. Volcanoes have a high fluoride content because fluorine is a component of magma that's released into the air as a gas during volcanic activity. The gas dissolves into nearby water and reacts with volcanic ash and dust, which is then released into groundwater and surface water. So samples of groundwater near volcanoes have been shown to have much higher concentrations. For example, near Mount Hood and Troutdale, shown to have a higher concentration of fluoride naturally in the groundwater. Same thing in around Mount St. Helens. So that's just it's around and also seen in seafoods, fruits, etc. This is a map. It's a little bit difficult to see this here, but in the Western United States, so think of like near volcanoes, we have more of those naturally occurring sources of fluoride. Parts of Africa have very high levels of naturally occurring fluoride in their groundwater, far, far above the World Health Organization guidelines of 1.4 milligram per liter. So specifically Nigeria, Ghana, Zimbabwe, and Kenya do. Also see high amounts in Asia, South America, and Australia. And this, hopefully this works here. This child here in Kenya is an example of a child that had exposure to water and water fluoride, high concentrations of fluoride. So some of these areas, we're talking 1,000% higher than the World Health Organization would recommend for optimally fluoridated water. So just to take you back, we're going to go way back to 1901. A dentist named Dr. Frederick McKay, he arrived in Colorado Springs and was puzzled to find that many of his patients had teeth with this dark brown stain, and they called that the Colorado brown stain. And what surprised him even more was that despite this discoloration, these same people had almost no decay. So these teeth that you're looking at here on the screen are extremely decay resistant, which doesn't seem logical, but that's what's happening. So driven by curiosity, he spent years trying to figure out what this was, and he discovered that this was because of naturally high levels of fluoride in the local water. So while too much staining, fluoride in the water can cause this brown staining, and we call that dental fluorosis, the right amount actually protected teeth from decay. So this laid the foundation for community water fluoridation. And that is considered one of the most significant public health achievements of the 20th century by the CDC. So in 1945 in Grand Rapids, they became the first city to fluoridate their drinking water. During a 15-year project, researchers monitored the rate of tooth decay among the around about 30,000 school children. After 11 years, the decay rate among those children after the fluoride was added dropped more than 60%. So this was considered a huge scientific breakthrough that promised to revolutionize dental care. And really it did. And it made tooth decay for the first time thought of something that was preventable for most people. So this is, let me get this, here we go. Sorry. Historically, when we think back, I think back even about my own grandparents in the early 1900s, rates of complete tooth loss among adults over age 65 were extremely high. Estimates around 60 to 70% of people were edentulous or they had no teeth. By the mid-20th century, as dental health improved due to better hygiene, dental services, and the introduction of water fluoridation, this significantly declined. Today, we see, according to the CDC National Survey of Oral Health, there was approximately about 12% of people are considered edentulous, have lost all of their teeth. So massive change. So why fluoridate the water? What about toothpaste? What about other things? What's happening here and why does this matter? So to answer this question, we need to understand how we get fluoride and what is happening in our bodies. So systemic fluoride and topical fluoride are the two different ways that they both prevent tooth decay, but they work differently. Systemic fluoride is what you eat, you ingest it, so it's systemically operating, usually through fluoridated water or alternative supplements. We'll talk about that in a little bit. And it becomes part of the developing teeth. Those are the teeth under the gum line when you are a child developing, helping to make them stronger from the inside. Topical fluoride is applied directly to the teeth, such as toothpaste, mouth rinses, or professional treatments like fluoride varnish, and it acts on that surface level of the tooth to help resist decay and remineralize areas that have early cavities. So in short, systemic fluoride strengthens teeth as they develop, while topical fluoride helps protect and repair teeth that are already present. One of the analogies I like to use is thinking of systemic fluoride like baking a cake. So you bake it and you add this special ingredient to the batter. It makes the cake itself really strong and more resistant to breaking or crumbling from the inside. Topical fluoride is like the frosting on the cake. It forms a protective layer, helps guard against damage, and fix those small cracks on the outside. They both work together, but you cannot add, you if you're taking fluoride supplements, which we'll again talk about here in a minute, if you're not consistently taking them, you can't add flour to an already baked cake. So it's really important to be consistent. And I'm going to get into a little bit more of why that's a problem here in a minute. This infographic here or graphic here is just trying to show you this whole big process about how teeth develop. But there's a blood supply, there's a process, and this is when that critical point and the most benefit from systemic fluoride occurs when teeth are developing. There is a little bit of a topical benefit when you swallow fluoridated water in your mouth. There's a little bit of a benefit to that, but the massive, hugest, biggest impact is when the teeth are developing and underneath the gum line and being made or formed. At the topical level, you have fluoride ions replace hydroxide ions. Small amounts, again, strengthen the teeth and the bones. If you have too much, like in this infographic here, you can get that pitting. This should have some brown stain on the outside, but there's like a sweet spot. And we know what that sweet spot is. And the water fluoridation levels recommended by the EPA and the WHO are 1.5 milligrams per liter. So again, water fluoridation is recognized as one of the top 10 greatest public health achievements by the CDC. One of the things really stress around this, you can't see the top of this maybe, I'm not sure, around health equity. So fluoridated water reaches everyone, obviously in the community that has the fluoride in the water, regardless of income or access. So it's considered passive prevention. You don't have to think about it. You're drinking the water, you're just doing it. Where active prevention, you have to go to the dentist, you have to go and seek it out, which would be a little bit more like what we talk about fluoride supplements, those pills that you can take that are given to you by the dentist or your child's pediatrician. This is an equity issue. It provides everyone in a community with access to the benefits of fluoride, regardless of their income, education, or their access to dental care. And it really does help close oral health disparities by protecting vulnerable populations such as low-income families and children who might not have regular dental visits or even the ability to afford fluoride treatments. So according to OHA, higher income children, I think Amy touched on this a little bit, or we will with the SMILE survey, are more likely to have a regular dental visit compared to lower income children. So this water fluoridation has shown to help close those oral health disparities. Oregon is ranked 49th in the country in water fluoridation. So nationally, this is an obviously national map here, but 72% of the population is served by fluoridated drinking water in Oregon as of 2023 was 49th. And these are the cities in Oregon that have fluoridated water. There are about 36 systems, which equate to about 944,000 people that do get access to fluoridated water in Oregon. This is doing that. So Portland is the largest metropolitan area of the United States that does not have community water fluoridation. Last time it was on the ballot in 2013, and they rejected the measure. I believe 61% of voters voted against it. So we still do not have fluoridated water in the Portland area. So this is an example. I put Canada up here, and this is a child with decay. So ending water fluoridation leads to a huge increase in childhood tooth decay. In Calgary, their fluoride was removed from their drinking water in 2011. Researchers found that second graders started presenting with higher rates of cavities compared to children in nearby Edmonton, where fluoridation had continued. So it's a good way to look. And claims data and looking at increased decay rates for children has led Calgary to rethink this. And 14 years later, they just voted to put fluoride back in their water. A common myth that we hear, a lot of misinformation, is that fluoride is banned in Europe. This is not true. It's not banned. About 5% of Europe receives water fluoridation from water systems. It does vary by country. Republic of Ireland gets 73% of the population benefits from community water fluoridation. 10% of Spain does, 10% of the UK does. Other countries do not fluoridate their water out of policy choices by their citizens. They still might receive some of the benefits of systemic benefits through other avenues, such as fluoridated salt and fluoridated milk, which is not something we have in the United States. They also do have different systems of care that I think it's important to mention, depending on the country. For example, in Denmark, all municipalities must provide school-based dental services, including exams and preventative care to the students. So it's very difficult to have apples to apples conversation when you have different systems of care and different delivery systems. So this is fluoride tablets, and this is a very timely conversation. So fluoride supplements are products that are developed to prevent, basically supplement for children in areas that don't have access to fluoridated drinking water. They come in pills, tablets, drops, lozenges. Sometimes they're with a vitamin, sometimes not. They're excuse me, they're an alternative, but they're really not an equivalent substitute for community water fluoridation because again, you have to be active about taking them. Um, they require consistent daily use and caregiver follow through, and that really is a barrier. So they don't reach as many children as water fluoridation. So I just want to point out something here that we have this is an old, I'm going to say this is old as of last week. And I'll get into that in just a second because prior to Halloween, this is current. So they've changed the recommendations on this as of Friday. So the FDA, about I think in May, they made an announcement they were looking to pull all prescription fluoride supplements that just talking about the previous slide. And they did an extensive safety review and public comment period to determine whether to take action regarding the removal of the product from the market. And just last week, they announced that they will be restricting the sale, and this is their language, of unapproved ingestible fluoride prescription drug products for children. And what they are doing, instead of removing them completely, they said nobody under age 3 should be taking them. And then they have a bunch of reasons why. They also stated that they're going to be launching a research agenda in the nation's first oral health strategy to close research gaps. So that's what's happening at the FDA level around fluoride supplements. And then this is I put this up here. I used to work in a pediatric office for years, and this is something I have seen. This is a child with early childhood caries, a 3-year-old that certainly probably would have benefited from, and maybe did benefit, I really don't know, from supplements. But it's important to note that, again, this is new information as of last Friday, but the American Association of Pediatric Dentistry, the American Dental Association, they continue to support the established fluoride supplement recommendations that I mentioned on that previous slide. So starting at age 0. So there's some discrepancies between what the FDA is, their rationale, and what we're hearing from the associations. The other thing that's happening at a national level, so Oregon will no longer be the 49th worst state for community water fluoridation because Utah has effectively completely banned it, and Florida has completely banned it. And these other states that are up here have legislation in their state legislatures looking at banning fluoride in their drinking water as well at the state level. So we will improve because of this, which is arguably not a great way to improve. And the costs associated with that, if you remove fluoride from the community water systems everywhere, completely ban all fluoride supplements, literal costs of $46 billion potentially. If so, I'll just leave it at that. We've not to mention the physical costs different. So what now? What are we looking at, and where are we at really in Oregon? What are we doing? Because we don't really have a lot of the population exposed to community water fluoridation. Again, thinking back to more active, not passive, but active things at the population level. We have community fluoride varnish programs, especially in schools. Fluoride varnish is it's a sticky, almost tacky, think of like sap from a tree. It's very thick. If your children have had it, you paint it on, it stays there for about 24 hours. So they do demonstrate 30 to 50% fewer cavities compared to non-fluoride populations. It's cost effective. Medicaid covers it. It's in several public health programs. We're doing it in our school dental sealant programs. Again, it's not as good as community water fluoridation because you have to have it done for you. It's also done through the age of 6 in a well child visit at your pediatrician's office. It's covered by insurance. It's a requirement, and hopefully that does not change. And that would be interesting and not great if it does. And I don't want to say that this is an alternative, but it is something that we have that is helpful. It's an adjunctive. It's called silver diamine fluoride. So it's a fluoride product. This has actually been around since the 1960s, where it started in Japan. It's a solution that combines with silver and has antibacterial properties and the fluoride, which strengthens the tooth enamel. So you put that on in this area to the left on the slide here is a child with decay, and they put that on, and the drop, it actually causes, it is odd, but it causes the decay to turn black, and it literally stops it from becoming deeper. So it has, I mean, it's a little bit of a double-edged sword. It's a great product. It does its job. It's a treatment. It doesn't prevent. We don't use it as a preventative agent. So it's not really apples to apples with water fluoridation, but it is something that we have. And then this bottom picture here is a picture of a dental sealant, and we do have a very robust school dental sealant program that Amy touched on. And the dental sealants are very effective at preventing tooth decay in children, and they go on permanent molars where you are more often to get cavities. So that is all I have, and now I have to figure out how to stop sharing. I have to find the button. There we go. There we go.
Oh, you found it. I was just about to pop on to give some direction, but you did it. Yeah. So Amy, Sarah, thank you for coming to share. I'm sure that wasn't even all of the knowledge the two of you hold. This was only only a piece. I was kind of taken back to some like high school science biology classes a little bit when we got into the ions and the things like that. You've had a request to share slides, but don't worry about that. I will be making sure that those get sent out. But I think for me, and I'm hopeful maybe some folks in our last few minutes here might have some questions or reflections. I just wanted to share that this conversation. I see a couple comments in the chat about the importance of having people, like the science behind these things, and having people who are dedicated to continuing to learn and share accurate scientific information that when it comes to our health and our well-being, especially when it comes to oral health. And I see that reflected in some of the comments in the chat as well, from folks who are really, I think, gaining a lot from the information that you shared. So I'm going to pause for a second and please, if anyone has any reflections or questions in our last 5 minutes or so together, I would love for you all to either ask them in the chat or come off mute. And please, Amy and Sarah are ready to answer those questions.
I will say I appreciate the info because at Family Building Blocks here in Salem, one of our main goals is to improve um, our health status events that we track, because it seems to be a major challenge even in Salem, where we have a little bit more access to dental providers around. So I appreciate the info because I think there's a lot of misinformation or misunderstandings. And then also, I think there's some hesitancy with parents not wanting to bring their kids in because of their past experiences. So it feels like we're kind of climbing an uphill battle with all things dental, especially when you consider some of these families don't have medical homes, are struggling with all the things going on with SNAP. And so sometimes dental can fall to the bottom of the list, which I do understand, but they don't understand. I don't think they have the full picture of how this can affect their child and development when they're eating certain things. If their child's in pain, they're not going to be eating certain things, and that could also affect them. So I appreciate all the info.
Thanks for sharing that, Drew. Also, just a reminder for folks that the Amy and Sarah's contact information will also be shared out in the follow-up email with the slides and the recording from today. And so I'm going to go ahead and assume that it is they would love to hear from you if you have questions, or if you would like to chat in a little more detail about yeah, what does it look like to respond to the unique needs that you're seeing in your communities, and what potential partnerships already exist between our oral health team and folks that are doing the work in different parts of Oregon. So please utilize them as well for future questions or collaboration. I'm sure that they would really be excited about that. And also, Amy and Sarah, please feel free to correct me if that's wrong and you're not excited about it, but I think you would be.
Thank you. We're very excited. Always happy to share anything we can.
Amazing. Time for maybe one last question or reflection if anyone wants to share. Or if anything popped up for you, Amy or Sarah, after the presentation you gave, you're welcome to leave us with some final thoughts. I also see Dolly's on camera, and Dolly also has some great final thoughts. So please.
I just want to appreciate this presentation and also make a confession, which is that I, Dolly, have not used my state benefit, which is a good one, to go to the dentist at all this year. It's November. So I, Dolly, am going to commit to make me an appointment based on this presentation, because I don't know what's going on, but I don't want a lot of what I learned. So I'm going to take care of myself. I don't know if there are others that are in this boat. You've been meaning to call and make that appointment. Thank you for this reminder. I am going to do that today.
Love. Good reminder for folks too. You're welcome to join Dolly in the intention setting of, if you have access to dental coverage, to use it. I'm sure that the dentist would love to see you. I know personally, my dental hygienist is a blast. She's so great. She's so funny. So part of me wants to go to the dentist just to be able to hang out with cool people, because there's cool people in oral health. But yes, thank you everyone for coming. Please share the information when it gets sent to you in the follow-up email. And yeah, we will see you for our final Public Health Modernization Chat of 2025 in December. So get ready for that, because it's going to be an awesome time and a great conversation. Thank you all for coming. Thank you, Sarah and Amy. We'll see y'all next time.
Thank you.